everyone. In this class, we'll try to learn about mechanics of breathing. Mechanics of breathing is a study of physical properties of lungs, airways, chest wall involved in the physiology of respiration. The mechanical properties of lungs can be studied in two conditions. When air does not flow into the lungs, that is the properties of static lung, and when air flows in or out of the lungs, changing the volumes, that is the properties of dynamic lung. The lungs are located in thoracic cavity, which is separated from abdomen by diaphragm, a large, thick, and dome-shaped skeletal muscle. The wall of the thoracic cavity is made up of sternum anteriorly and vertebral column posteriorly, with 12 pairs of ribs and intercostal muscles, internal and external intercostals that present between the ribs, hinged to the sternum and vertebral column. The rib cage is hinged between the vertebral column and sternum. It is raised and lowered during inspiration and expiration, respectively. The movement of the rib cage along with the diaphragm brings about changes in various volumes and pressures in the thoracic cavity that result in inflow and outflow of air across the respiratory passages and lungs. The inspiration. Muscles of inspiration cause expansion of the chest and increase the elastic recoil of the chest wall. This makes the intrapleural pressure more negative that helps in expansion of the lungs due to which the air is sucked in. The inspiratory muscles are divided into two categories, primary and secondary also called as accessory muscles. The diaphragm and the external intercostal muscles are the primary muscles of inspiration. The diaphragm is the main muscle of inspiration, which is skeletal muscle. Inflation of the lungs is caused primarily by the contraction of the diaphragm. The contraction of the diaphragm expands the thoracic cavity in two ways. The diaphragm is dome shaped and attached to the lower six ribs and xiphoid process of the sternum. Thus, when it contracts, the dome is flattened and abdominal contents are pushed downwards so that the thoracic cavity uh, enlarges into rostro-caudal extent. Thus, the vertical diameter of the thoracic cage increases. So this is the diagram showing the contraction of the diaphragm. When diaphragm contracts, it is pulled down, and the the vertical diameter of the thorax is going to increase. Exactly opposite thing is going to happen during respiration. When muscle contracts, relaxes, the diaphragm is going to move in upward direction, and the thoracic cavity, the vertical diameter of the thoracic cavity is going to reduce. Contraction of the diaphragm also pushes the rib cage outward and enlarges the thoracic cavity into anterior, posterior, and lateral planes. Thus, the ability of the diaphragm to expand the thoracic cavity lies mainly in its dome-shaped configuration. During quiet respiration, the diaphragm moves towards abdomen by about 1 to 2 centimeters. However, during forced inspiration, the descent of diaphragm occurs about 10 to 12 centimeters, that greatly increases the thoracic volume. The inspiration is significantly compromised during the following conditions: moderate to severe obesity, pregnancy, especially in third trimester, and tight clothing around the thoracic and abdominal walls decrease expansion of the lungs by reducing the effectiveness of diaphragm in enlarging the thoracic cage. Diaphragm is innervated by phrenic nerves, that is C3 to C5 cervical roots. Lesion in the phrenic nerve results in paralysis of the diaphragm. It should be noted that when phrenic nerve is damaged, the portion of diaphragm of the side moves up rather than coming down during inspiration. So this grossly impairs the ventilation. External intercostal muscles are present obliquely between the ribs in forward and downward direction. Their attachment to the lower ribs is more forward from axis of rotation. Therefore, contraction of external intercostal muscles raises the lower ribs adequately. The contraction of the external intercostal muscles has two effects. The first one is transverse and antero-posterior diameter of the thorax is going to increase. This occurs by the two mechanisms. The second to tenth ribs rotate upward and outward by movement similar to the movement of handle of bucket. That is why it is called as bucket handle effect. So this increases the transverse diameter of the thoracic cavity. The upper four ribs rotate the sternum in upward and outward direction by movement similar to the handle of water pump. So that is why it is called as pump handle effect. This mainly increases the vertical diameter of the thoracic cage, though anterior-posterior diameter also increases to some extent. The rib cage and the tissues between the ribs become stiff. This helps the thoracic cage to withstand better, increasingly negative intrapleural pressure. So this diagram showing both the pump handle movement and bucket handle movement. So this is pump handle movement, that is the moving of uh, the sternum uh, anterior to posterior direction, and this is uh, the bucket handle movements of the lower ribs in vertical direction. Accessory muscles of inspiration. So accessory muscles, they assist in forced inspiration. These are scalenes and sternocleidomastoids. Scalene muscles of the neck are inserted to the upper two ribs. They are brought into play during deep breathing. They elevate the upper part of the rib cage to further increase the thoracic volume. Sternocleidomastoids are inserted into upper two ribs and top the sternum. These muscles lift the sternum outward and elevate the rib cage. This contributes to the pump handle effect and increases the thoracic volume. The neck and back muscles. Contraction of neck and back muscles during forced respiration increase the thoracic volume in two ways. Firstly, they elevate the pectoral girdle, that increases the cross-sectional area of the thorax. Secondly, they extend the back, that increases the vertical length of the thorax. Some important muscles of neck and back that assist forced respiration are posterior muscles of neck, digastric muscles, myohyoid, and posterior muscles of the upper back. Muscles of respiratory tract. The contraction of the ala nasi, levator palati, cheek muscles, and other muscles of upper respiratory passage decrease airway resistance. Thus, they facilitate inspiration. So, this is the sequence of events during inspiration. The contraction of the diaphragm leads to expansion of the thoracic cage vertically. Uh, the intrapleural pressure becomes more negative. That increases the transpulmonary pressure, leads to inflation of the lungs. So that decreases the alveolar pressure, which becomes subatmospheric. So air flows into the airways and lungs. So uh, then cessation of the contraction of the inspiratory muscle ends the inspiration. Muscles of expiration. Quiet expiration uh, is purely passive process. Therefore, there are no primary muscles of expiration. However, expiratory muscles come into play during forced expiration. These muscles are called as accessory muscles of expiration, that include abdominal muscles, intercostals, and neck and back muscles. The muscles of abdominal wall that take part in expiration are internal oblique, external oblique, and transverse abdominis. Contraction of these muscles increases intra-abdominal pressure and pushes the diaphragm upward into the chest cavity. This decreases the rostro-caudal diameter of thorax and increases the intrapleural pressure. The internal intercostal muscles pull the rib cage downward and decrease thoracic volume both in antero-posterior and transverse diameter. The muscles of neck and back that lower the pectoral girdle decrease the cross-sectional area of thorax, and muscles that flex the trunk decrease rostro-caudal diameter of the chest cavity. Following three important points should be noted for the muscles of expiration. During forced inspiration, axillary muscles are used to increase lung volume rather than to overcome the resistance to airflow. whereas during forced expiration, accessory muscles are used to mainly to overcome the resistance to airflow. Quiet expiration is purely passive. However, exception to this is the individual suffering from lung diseases like bronchial asthma, in which airway resistance is very high. The strength of expiratory muscles is important uh, in endurance training like running. Therefore, long distance runners, physical exercise are all advocated to strengthen their abdominal and chest muscles as a part of training programs. So this is the events that occurs during expiration. Relaxation of inspiratory muscle lead to dropping of the rib cage. Intrapleural pressure becomes less negative. There is a decrease in the transpulmonary pressure, and that leads to recoiling of the stretched lungs. There is a decrease in the alveolar diameter. Alveolar pressure gradually increases, and it becomes more than atmospheric pressure, and air is pushed out of the lung. That leads to expiration. Pressure changes in the thoracic cavity. Various pressure exist in different structures in the thorax. The pressures are generated and modified in different phases of respiration. Changes in different pressures in the thoracic cavity that results in breathing are intrapleural pressure, transmural pressure, and alveolar pressure. Going to see what are those. Intrapleural pressure is the pleural pressure is in the it is the pressure in the pleural space is called as intrapleural pressure. Pleural space is the space between lungs and chest wall, that is the virtual space between visceral and parietal pleura. The intrapleural pressure also affects the pressure in other regions of the thoracic cavity like interstitial space surrounding the airways of the lung, the space around the heart and great vessels, pressure inside and outside the esophagus when esophagus is not in peristalsis. Thus, intrapleural pressure is the pressure everywhere in the thorax except the pressure in the airways and in the lumen of the thoracic and blood vessels and lymphatics. How intrapleural pressure is created and why it is negative. The pleural space is relative vacuum. The lungs have the tendency to collapse and chest wall has a tendency to expand. Therefore, the elastic recoil effect of the lung and chest wall are exerted equally but in opposite directions. Lung recoils inwardly and chest wall recoil outwardly. These equal and opposing forces cause intrapleural pressure to be negative, that is less than the atmospheric pressure. Pleural pressure is negative during quiet breathing and more negative during deep inspiration. During forced expiration, only intrapleural pressure may become positive. Okay, so this is how the negative pressure is created. The chest wall, it always tries to move in outward direction, and the lung, because of its virtue of elastic tissue, it tries to uh, collapse. So that is why the intrapleural pressure is always negative, and it becomes more negative during inspiration. Okay, so as the thoracic chest cavity tries to move in opposite direction towards, I mean, to the lung. In quiet breathing, the interpleural pressure is relative to atmospheric pressure during expiration is about minus 2.5 to minus 4 mm of Hg, and during inspiration it is about uh, minus 6 mm of Hg. In forced breathing, however, during forced expiration, intrapleural becomes positive, and during forced inspiration, it becomes further negative. It may go up to minus 30 mm of Hg. Measurement of intrapleural pressure. An intrapleural pressure reflects esophageal pressure. In practice, it is measured by recording the intraesophageal pressure by introducing balloon catheter through the mouth of the esophagus. Okay. So this diagram showing different pressure during inspiration and expiration. So this is inspiratory phase and this is expiratory phase. So this is intra-alveolar pressure during inspiration. Uh, as the intra-alveolar pressure becomes negative, the air gushes inside, and during expiration, uh, the intra-alveolar pressure increases, and because of which the air is expired. Okay, so these are the intrapleural pressure changes. It is always negative. Okay, and when inspiration starts, the thoracic, because of the expansion, there will be more negative intrapleural pressure is created. Okay, so because of which air enters inside the lung, and during expiration, because the thoracic cage recoils, and the intrapleural pressure reaches -6 to -3, that increases the alveolar pressure and air is expired out of the lungs. Okay. So this is the volume of air taken in during inspiration and expiration. So almost around 500 ml, 450 ml, I mean 500 ml of air is taken into the lungs. That is tidal volume. In upright posture, the intrapleural pressure is about -5, 2.5 centimeters of water and at the base of the lung, and -10 centimeters of water at the apex of the lung. This apex to base increasing negative gradient of intrapleural pressure is due to the effect of gravity. In standing position, vacuum in the intrapleural space is greater in apex and less at the base of the lung. In supine position, lying on one side creates the intrapleural pressure gradient in transverse direction. As there is no gravitational force in the outer space, intrapleural pressure gradient is absent. Significance: it is going to facilitate inspiration. Expansion of the thoracic cage, as occurs during inspiration, causes intrapleural pressure to fall. A decrease in intrapleural pressure helps in lungs to expand, which in turn results in inflow of air into the lungs. Thus, fall in intrapleural pressure facilitates inspiration. It is going to maintain the shape of the chest and size of the lungs. Intrapleural pressure maintains normal shape of the chest wall and lungs as it resists the recoiling of these structures. Loss of normal intrapleural pressure results in lungs collapse and barrel shaped chest. The clinical significance of intrapleural pressure is observed when chest wall is perforated and air enters in the pleural space. The normal pleural pressure is subatmospheric. Thus, when a connection is made between the atmosphere and the pleural space, the air moves into the pleural space. That is, the air moves from regions of high to low pressure, and intrapleural pressure becomes atmospheric. This condition, in which air accumulates in the pleural space, is called as pneumothorax. Due to the loss of normal intrapleural pressure, in this condition, lungs collapse immediately due to the inward recoiling. The rib cage expands outward due to its outward recoiling. In such situation, transpulmonary pressure is zero because the pressure difference across the lung is eliminated. So the causes of pneumothorax: injury with a knife, gunshot, which the chest wall is punctured, and in diseases in which the lung ruptures into the pleural cavity, example rupture of the lung abscess or rupture of the parenchymal bulla in severe coughing. During aspiration, the pleural fluid for analysis, air enters into the pleural cavity due to the faulty technique that may result in pneumothorax. As a part of therapy in some lung diseases, for example, the treatment of tuberculosis, the pneumothorax is purposefully created by inserting sterile needle into the pleural cavity. So this is the mechanism of development of the pneumothorax. Okay, so when the chest wall is punctured because of the negative pressure, the the air is going to enter into the pleural space, which is which is going to produce pneumothorax, and it is going to push the lung to the one side. The transmural pressure is the pressure difference across the airway or across the lung wall. There are two major transmural pressures involved in breathing: transpulmonary pressure and trans-airway pressure. Transpulmonary pressure is the pressure difference across the lung wall. This is measured by subtracting the pleural pressure from alveolar pressure. Transpulmonary pressure is the pressure that keeps the lungs inflated and prevents the lung from collapsing. Trans-airway pressure is the pressure difference across the airway, which is the difference between the pressure inside and outside the airway. Trans-airway pressure is important in keeping the airways open during uh, forced expiration. Alveolar pressure is the pressure inside the alveoli. Change in the alveolar pressure moves the air in and out of the lungs. During inspiration, alveolar pressure decreases, becomes subatmospheric, and sucks the air into the lungs. And during expiration, the alveolar pressure increases, that removes the air from the lungs. The normal value during inspiration is approximately -1, and during expiration it is +1. So this is a diagram showing alveolar pressure, trans-airway pressure, and transpulmonary pressure. Okay. So trans-airway pressure is a difference in the pressure uh, between the airway inside and outside. Okay, so whereas transpulmonary pressure is the difference between alveolar and intrapleural pressure. Significance of transmural and alveolar pressure. At the end of expiration, when there is no flow of air into the airways, the alveolar pressure is zero, that is equal to atmospheric pressure. Transpulmonary pressure is the difference in the alveolar pressure and the pleural pressure. It is therefore is plus 5 centimeter of water, that is 0 to minus uh, into -5, that is equal to +5 at the end of expiration. Transpulmonary pressure is always positive in normal breathing. The transpulmonary pressure is also referred as distending pressure, as it keeps uh, as it is helps in the inflation of the lungs. When transpulmonary pressure becomes more positive, the lungs are more inflated.